Hello all, welcome you to my YouTube channel Tcam Tutor. So the next question discussion we can see. So the next question was in the rheumatoid arthritis features they have given in the option. So in that one option is not matching with the rheumatoid arthritis features. So I have given you here so much options are there. So here one of the option like these red markings, okay, so these red markings actually these are not features of the RX. So whichever option you are getting in the question, accordingly you have to mark it. Okay, so here PIP and DIP joints involved equally, that is not a feature of rheumatoid arthritis. Okay, PIP means proximal interphalangeal joints and distal interphalangeal joints. Okay, these equally they are not affecting, only one of them will be affecting in the rheumatoid arthritis, one of the joint. And another one thing is pathology limited to articular cartilage. It is not limited to articular cartilage, it is fully that synovial membrane, it's fully getting inflammation. Then women are more commonly affecting than men, that is true. Then rheumatoid nodules are seen in 20% of the patient, that is also true. And 20% of the patients have extra articular features, that is false. Okay, so that is also not a feature of rheumatoid arthritis. Then positive for the anti-IgG antibody. Then juxta articular osteoporosis you can see. Then morning stiffness will be there. C-reactive protein indicates better prognosis. So that is not a that is also not a feature of rheumatoid arthritis. So these are the options are there. So two types of questions they have asked related with rheumatoid arthritis features. So these type of options if you are getting, so these are the exceptional cases. Okay, PIP and DIP joints involved equally, that is not a feature. Pathology limited to articular cartilage, that is also not a feature. 20% of the patients have extra articular features, that is also not a correct answer. C-reactive protein indicates better prognosis, that is also not a correct answer. Okay, so these are the exceptional features of the rheumatoid arthritis. Next, they have asked about the features of the seronegative spondyloarthritis. So, in that, which one is the exceptional feature? So, strong association with the HLA-B27, that is that is true only. Then negative rheumatoid factor, that is true only, because seronegative spondyloarthropathy means it is a group of inflammatory arthritis which is having negative rheumatoid factor. Okay, seronegative spondyloarthropathy means it is a inflammatory arthritis where the rheumatoid factor is negative. Okay, it is a group of inflammatory arthritis. Group of inflammatory arthritis means this psoriatic arthritis, enteropathic arthritis, ankylosing spondylitis, reactive arthritis. So these are the four main seronegative spondyloarthritis. Okay, which means it is an inflammatory arthritis. They will be having this HLA-B27. So that type of chromosome is there. Plus they have a negative rheumatoid factor. So that type of people, they are getting an inflammatory arthritis that is called as seronegative spondyloarthritis. And seronegative spondyloarthritis always it is asymmetrical polyarthritis or oligoarthritis. Okay, asymmetrical, you can see here there is features other asymmetrical, inflammatory, oligoarthritis, or any one of the joint will be affecting. Plus it is asymmetrical, it is not affecting both the sides simultaneously, only one side will be affecting. Okay, so the exceptional feature of the seronegative spondyloarthropathy is symmetrical polyarthritis. Okay, it is not a symmetrical, it is asymmetrical oligoarthritis. Okay, then next one, enthesitis. So enthesitis means where the tendon is inserting into the bone area, no? So that portion is called as enthesitis. So there you will be getting inflammation. Okay, so here example they have given gluteus medius insertion or plantar fascia origin. Okay, Achilles tendon is getting inserting, so that points are getting inflamed. That is also a typical feature of seronegative spondyloarthropathy. Then extra articular features including uveitis. Other than arthritis, what are the other symptoms you will be getting in the seronegative spondyloarthropathy is psoriasis will be there, uveitis will be there, sterile urethritis or prostatitis, inflammatory bowel disease, aortic root lesions like aortic incompetence, conduction defects. So this type of extra articular features you can see in the case of seronegative spondyloarthropathy. So these are the main clinical features of the spondyloarthropathy, which means it is a group of inflammatory arthritis which is having negative rheumatoid factor and HLA-B27 association. Next question is, a young woman complains of a painless ulcer in the genital area. It is associated with a non-tender inguinal lymphadenopathy. So, a painless ulcer and non-tender inguinal lymphadenopathy. There is no pain in the lymphadenopathy. Lymphadenopathy means enlargement of the lymph node. Okay. So, in which condition you can see that painless ulcer and there is painless lymphadenopathy. So that is usually seen in the syphilis condition. Okay, you can see here the first one is chancroid. So that is a causative organism is Haemophilus ducrei. So here also you will be getting ulcer, but it's a painful ulcer. Okay, painful ulcer, and you will be getting an exudation, that is grey to yellow color discoloration will be there. Okay, and if you just examine the organism, it's like a school of fish. Okay, so in that way this organism is arranged. So that type of pattern you can see. Then genital herpes, so that is causative organism is HSV1 and 2, and there also you will be getting multiple ulcer, that is also painful. Okay, the pictures are here. Then granuloma inguinale, or otherwise known as donovanosis. Okay, so the causative organism is Klebsiella granulomatosis, and here also you are getting painless ulcer. Okay, here you are getting painless ulcer, but here lymphadenopathy is not there. Okay, so that because of that reason you can this granuloma inguinale will not comes under the correct answer. Okay, painless ulcer is there, but here without lymphadenopathy you are getting in granuloma inguinale. In syphilis, it is a painless ulcer. Causative organism is Treponema pallidum. Okay, painless ulcer is also there, and along with it you are getting this lymphadenopathy. Okay, painless lymphadenopathy is there in the syphilis, that they have not mentioned here, but painless lymphadenopathy you can get in the syphilis. Okay, and the organism will be corkscrew shaped organism, and you can identify the syphilis in the dark field microscopy. Okay, by using dark field microscopy you can identify the syphilis. Okay, you can see the picture they have given. There is a it is a dark, in that white color structure is there, so that is the syphilis, Treponema pallidum organism. Then lymphogranuloma venereum, here also you are getting painless ulcer, but here painful lymph node will be there. Okay, so lymphogranuloma venereum, so causative organism is Chlamydia trachomatis. Here also you are getting painless ulcer, but painful lymph node will be there. So the answer will be syphilis. Okay, painful ulcers you can see in chancroid, genital herpes. Painless ulcers you are getting in granuloma, syphilis, lymphogranuloma venereum. But in granuloma inguinale, lymphogranuloma venereum, in both these cases you are getting like granuloma inguinale there is no lymphadenopathy. Lymphogranuloma you are getting painful lymph node. In syphilis, painless ulcer plus painless lymphadenopathy will be there. So the answer will be syphilis in this condition. Okay, painless ulcer, painless lymphadenopathy you can see only in the syphilis. Chancroid is a painful ulcer. Genital herpes, there is also painful ulcer. Granuloma inguinale you are getting painless ulcer plus without lymphadenopathy. So because of that reason syphilis will be the correct answer. Next question was, a elderly female presenting with a dribbling of urine on coughing and straining. What type of urinary incontinence is she suffering from? Okay, so coughing and straining, like doing some activity, suddenly it is creating a abdominal pressure, and through that way dribbling of urine is happening. So that is the condition. So that is usually seen in the stress incontinence. Okay, stress incontinence means there is an increased abdominal pressure is happening because of the coughing, straining, or any other activities. Okay, and because why it is happening means there is a weakness in the pelvic floor. Okay, due to some of the reasons there is a weakness is there in the pelvic floor, and because of that whenever you are getting an abdominal pressure, so suddenly there will be this dribbling of urine will be happening. So that is called as stress incontinence. Okay, urge incontinence is there. So urge incontinence means it's an involuntary contraction of the bladder muscles. Okay, involuntary contraction of the bladder muscle, which means oversensitivity, like overly they are getting contraction. Okay, overly the patient is going for the urination, there is no such a strain or something, repeatedly the patient has getting that urgency to go to the washroom. Overflow incontinence is because of the blockage of the urethra. Okay, so there is a blockage is happening in the urethra due to maybe this prostate gland enlargement or a tumor formation. Okay, because of there is a blockage is happening. So when this blockage is removing, so what happens, suddenly you will be getting excessive flow of urination will be happening, that is called as overflow. Then neurogenic incontinence is there. So neurogenic incontinence because of the impaired function of the nervous system. If the nervous system is not functioning properly, what happen, like improper impulse will be getting into the urinary bladder, and through that way sometimes they will be getting excessive urination, and sometimes they will not be getting the proper urination. Okay, because of the nervous system problem, if you are getting excessive urination, that is called neurogenic incontinence. So here they are specifically they are telling this type of activities they have done, then after that they are getting this dribbling of urine, so that is called as stress incontinence. So here they specifically they are mentioning the activities they have done, the coughing and straining, after the activities only they are got the dribbling of urine. So that's why this the patient is suffering from stress incontinence. Okay, so in stress incontinence there is a weakness of the pelvic floor muscles are there, and whenever they are doing some pressure is exerting in the abdominal area, suddenly it will result in the dribbling of urine. Okay, so in urge incontinence you are not getting a particular activities you are not doing, suddenly like a half an hour or 1 hour, during that there is a tendency is coming and they are going for the urination. Overflow, there is a particular one blockage is there, after removing that suddenly there is an excessive urination. Neurogenic because of the nervous system problem you are getting. Okay, so the answer here for this question is stress incontinence. Next, this is a model question. So this type of one question they have asked in the MOH examination, not the same one, it is similar to this. Okay, an 8-month-old girl suddenly developed a high fever. Her pediatrician examined her and found there is no signs of upper respiratory tract infection, no meningitis or encephalitis. 2 days later, the girl's fever reached around 105 degree Fahrenheit and she suffered a febrile seizure. By the time child was brought to the pediatrician's office, her temperature had dropped and doctor noted a generalized papular rash. Okay, what was the doctor's most likely diagnosis for this child? So the answer is roseola infantum. Okay, so these all rashes like erythema infectiosum, hand, foot, mouth disease, measles, roseola infantum, rubella, these all conditions will create rashes in the child. Okay, so in that you have to understand is, if there is a face and the trunk area only, if you are getting rashes, so the conditions will be measles, rubella, erythema infectiosum. In all these cases, measles, rubella, erythema infectiosum, in these cases you will be getting rashes in the face and trunk. In chickenpox also you are getting face and trunk. Roseola infantum affect the rashes only in the trunk area. Then hand, foot and mouth disease you will be getting in the this hand area and in the palms and sole. Okay, in both these areas only you will be getting rashes. So like that you can divide the rashes. Okay, measles, rubella, erythema infectiosum, chickenpox, these are all happening in the face and trunk area. Roseola infandum, you are getting rashes only in the trunk, and hand, foot and mouth disease you will be getting in the palms and sole. Hand, foot and mouth disease is happening because of the Coxsackie-A virus. Incubation period is 3 to 6 days, and children less than 5 years. Okay, so that children, they used to get this condition, so they will be getting maculopapular or vesicular rash, especially in the palms and soles, and in the mouth area also they will be getting. Okay, so mainly they will be having the rashes. So rashes will be blister, like a vesicular type of rashes will be getting, and that is painful. So such type of rashes they will be getting, and this is spreading through the saliva. It is a contagious viral infection, and it will go within 7 to 10 days. Okay, 3 to 6 days is incubation period. Within 2 weeks it will go from the body. Then chickenpox. So chickenpox, so the causative organism is varicella zoster virus. Incubation period is 16 days. Less than 5 years old children, they can get it. Along with the rashes, they will be having fever will be there, malaise, sore throat, low appetite will be there. Okay, and this they will be having crusted papules, you can get it, vesicles and pustular papules, macules and papules. So this type of different type of rashes you can see in the body. Full body they will be affecting in chickenpox. Then erythema infectiosum, or otherwise known as fifth disease. So the causative organism is parvovirus B19. So incubation period is 7 days. Okay, children they used to affect is 5 to 15-year children. Okay, not for the infants. Okay, it is affecting 5 to 15-year old children. So the rashes will be slapped cheek appearance. This is the main clinical feature for identifying the erythema infectiosum. Okay, slapped cheek appearance. Okay, and then you can get lacy rash type of maculopapular rash in the body. You will be getting in the trunk area, face. Then fever will be there, running nose will be there, headache, diarrhea will be there. Then after that facial rashes will be there, spreading to trunk and extremities. Then measles, or otherwise known as rubeola. Okay, so virus is measles virus. Incubation period is 14 days. So here you will be getting fever and then cough, coryza, conjunctivitis. So simultaneously these all symptoms you will be getting. Cough, coryza, conjunctiva. Then Koplik spots is the main important spot for identifying the measles, that you will be getting in the palate and buccal surface. Okay, then after that you will be getting maculopapular rash on the face or neck area, and the complication is pneumonia and encephalitis. Then Roseola infandum, or otherwise known as exanthem subitum. This is usually affecting the children less than 2 years. Okay, so here the baby was 8 months old, so less than 2 years. So that's why Roseola infandum has came as answer. And the causative organism is human herpes virus 6 and 7. Incubation period is 9 days. And here main thing is high fever will be there for 2 to 5 days. Then after that the fever will be coming down. Okay, it will, fever will go on its own. Then you can see blanching rash or macular or maculopapular rash you can see in the trunk area. Okay, only in the trunk you will be getting the rashes, and in the tongue you can see uveo palatoglossal spot will be there. Complication of the Roseola infandum, you are getting febrile seizure. So these all features you can see in this history. Then rubella, or otherwise known as German measles. Rubella virus is the causative organism. Incubation period is 14 days. So acute onset of pink maculopapular rash you will be getting, and it will be last for 3 days and it will go. Okay, and along with it you will be getting lymphadenopathy will be there. Okay, lymph node swelling will be there around the head and neck region. So these are the differentiating factors of the each organisms. Okay, so these are the main viral infections which is used to affect in the children. So here they have told it is an 8-month-old children is there. 8-month-old, that is the age, and the high fever was there. Then after the 5 days the fever has become reduced. You can see they have got a febrile seizure, then they have got a papular rash in the body. So the answer is roseola infantile. So I have given you the differentiating points also. If there is another question is coming, so you through this way you can just answer it. Next, causative organism for shingles, that is varicella zoster virus, because varicella zoster virus first they will act as a chicken pox, then it will reactivation, that is called shingles. Then vulval irritation, hyperemic edematous vaginal vault with the odorless vaginal discharge, that usually seen in the candidiasis infection. And the diabetes patient with the most common oral infection they are getting is candida. Okay, so the diabetes patient, if they are getting oral infection, the most causative organism is candida. And then another one is least common site for osteoarthritis. This one question was there. So answer is carpometacarpal joint of thumb area. So here you don't get OA condition as much. Okay, so in the hands, specifically they are involved in the distal interphalangeal joint, then proximal interphalangeal joint, first carpometacarpal joint. Okay, so these are the areas first of all joints are affecting. Okay, then some of the other features which is not this osteoarthritis is not getting involved, that is metacarpophalangeal joint. It does not involve in the wrist joint, and carpometacarpal joint. Okay, it does not involve the carpometacarpal joint except at the base of the thumb. So this carpometacarpal joint at the base of the thumb, they can get osteoarthritis, but it is least one. Okay, it can affect it, but not in the first position. Later onwards in the chronic stages you will be getting OA in the carpometacarpal joint. So the commonly you will be getting in the hip joint, knee joint, and in the distal interphalangeal joint. Okay, proximal interphalangeal joint, these are the first joints. First of all you will be getting OA condition, then in the next when it is coming chronic, so that time you will be getting carpometacarpal joint at the base of the thumb. So that's why the least common site answer you will be getting is carpometacarpal joint of the thumb area. Okay, in the starting time, hip joint, knee joint, distal carpophalangeal, these are the areas first of all the OA will be affecting. In the carpometacarpal joint will be affecting, but it will be taking little bit time. Okay, like in the second wave you will be getting in the carpometacarpal joint of the thumb area. Okay, so wrist joint, elbow, shoulder joint, carpometacarpal, these are all you can get it, but afterwards only. Okay, so that's why the answer is carpometacarpal joint of the thumb. Then another one question was came like fear of dust and germ, and because of the repetitive washing was there, so such type of one question came. Then answer is OCD. Okay, because of the fear the patient will be repeatedly doing some of the activities. Okay, the fear of germs of dirt, then fear of making a mistake, need for order, neatness, symmetry or perfection, fear of causing harm to yourself or someone else. So such type of fear will be there. To overcome that fear they will be doing repeatedly some of the activities they will be doing. So that is the main symptom of the OCD. Okay, because of the some of the belief, to remove that belief they will be doing repeatedly some of the activities. Okay, so that is the main symptom of obsessive compulsive disorder. Next one was normal fear for being in the public place. So the answer is agoraphobia, and they have given some anosmia symptoms. Then cloudy and opaque cornea is cataract. Then gestational diabetes risk factor. So here the option was not correct, so I am giving you these are the risk factors, so which is not coming, so that you have to choose for the exam. Okay, so these are the risk factors for getting gestational diabetes. BMI is more than 30 kg per meter square, family history of diabetes, previous gestational diabetes, previous macrosomic baby, okay, which means more than 4.5 kg baby has got born in the previous pregnancy, and the Southeast Asian, Black, Caribbean, Middle Eastern ethnic origin. So this type of people, they are all comes under the category of risk factor of gestational diabetes. Okay, so these are all risk factors. So just to see the option, then accordingly you have to answer it. Okay, these are the main risk factors for getting gestational diabetes. Then another one question, the process by which the body responded to stress, that is fight and flight response. Then another one question similar to this one question you have got in the MOH examination, that is a 48-year-old man present with the complaints of facial puffiness, frothy urine, hypertension, and he gives a history of infection with the hepatitis B. In the urine examination, microscopic hematuria is there. Then histopathological image of kidney biopsy shows a spike and dome appearance. So spike and dome appearance you can see in the membranous nephropathy. So here what is happening means it is an autoimmune system condition. So here our kidney in kidney will be containing glomeruli. Okay, you can see the glomeruli. So this glomeruli will be attacking. Okay, and it getting inflamed. Okay, so the glomerular basement membrane will get inflamed because of the autoimmune activity. Okay, and because of that what happened, that filtering of the kidney will not be happening properly, and this is usually happening in the 30 to 50 year age group people. They used to affect this membranous nephropathy. So the antibody is anti-PLA2R. Okay, that is an antibody. So that antibody will come and attacking this. This is the podocyte. Podocyte means it is a cell of the glomerular basement membrane. Okay, so this antibody will be coming and blocking this podocyte, and through that way the podocyte action will not be happening, and it result in this spike-shaped structures will be forming in the glomerular basement membrane. So there is a inflammatory changes are happening. So that's why this spike appearance and thickening of the glomerular basement membrane, these are all happening, and because of the podocyte is not working, the proteins will be started to flowing through the urine. So you will be getting nephrotic syndrome. Okay, so these are the main things regarding with the membranous nephropathy. Okay, so nephrotic syndrome symptoms, you are getting facial puffiness is there, frothy urine because protein is passing through the urine, so that's why you are getting this frothy urine. Hypertension because of the glomerular basement membrane has become inflamed, you are getting hypertension. History of infection with the hepatitis B. So first of all they have got hepatitis B infection, and after that against this there is an autoimmune action is generated, and through that way kidneys glomerular basement membrane has become infected, inflammation, and this spike and dome appearance is happening. Okay, so the which antibody is creating anti-PLA2R. Okay, so this antibody will be coming and making the glomerular basement membrane inflammation, and through that way podocyte damage is happening, and through that way proteins are started to passing glomerular basement membrane. Inflammation will be there, so that inflammation will be spike. Okay, spike shaped structure is forming. So that is typically seen in the membranous nephropathy. So the clue for diagnosis was the recent infection, then frothy urine, hypertension. These are all indicating proteinuria, severe hypertension, autoimmune disorder. So that all this these are the things for identifying the membranous nephropathy. Then another one question, which occupation or exposure may cause sterility in females? So lead, carbon monoxide, mercury was there, then agricultural insecticide. So among this agricultural insecticide is the main exposure which is causing sterility in females. So these are the main questions which is asked in the MOH examination. Thank you.